My name is Andy Jawa. I'm coming from Boston, New England Baptist Hospital. I'm going to be presenting on RSA for fractures, principles, and technical tips. This is primarily a technical talk, but I'll start off with a couple of basic evidence-based principles. These are my disclosures. So the evidence-based principles that should apply. Number one, non-operative treatment should be the mainstay for most fractures. There are 8 RCTs looking at this, and we should be treating most of these non-operatively. There is definitely data, 2 RCTs that support RSAs better than hemiarthroplasty. We used to think that you could throw away the tuberosity with a reverse when you did this for a fracture, but we know tuberosity healing is critical, and definitely improves outcomes. And there's definitely data to support both cementless and cemented RSA for fracture. I'm really going to focus on technical tips. So I have 5 technical tips for RSA for fracture. Number 1, use the biceps as your guide to get into the joint. Number 2, slightly less lateralization, both on the glenosphere and the humerus. Some tricks for stem placement, the black and tan cement technique by John Levy, and how critical horizontal and vertical tuberosity fixation is. So number 1, the biceps is your guide into the joint. There's a lot of hematoma, the planes aren't clear, so use the biceps to get into the joint. We have been taught in the past that the fracture line is in the bicipital groove, but it really isn't. It's typically lateral, as you can see here on the left, or just medial to the bicipital groove, but use the biceps to get into the joint. Then at this point, remove your humeral head. Sometimes you require an osteotomy from your lesser tuberosity or your greater tuberosity. Then I use a pointed towel clamp to take out that humeral head at this point. And then it's really critical that you tag the tuberosities at this point, usually with your final sutures. If you do it after you put in your glenosphere, it's going to be very difficult, especially for your posterior tuberosity and your infra and teres afterwards. This is anecdotal, but I like to go slightly more medialized when I do fractures. I want to over-reduce the tuberosity. So I want to use a medial glenoid and a medial humerus. And when I say medial, I typically don't do 0 center of rotation. I mean like 2 or 4, as opposed to 6 or 10 millimeters of lateralization, and an inlay humerus, which is a medial humerus. You certainly can do a lateral humerus. This is one of mine, but you can see how the tuberosity is lateral to the acromion. It's a little bit of a stretch. And similarly, you can do a lateralized glenosphere and a medialized humerus, but again, you can see how the tuberosity is lateral to the acromion. It's a little bit of a tighter pull. J.P. Warner showed us previously how to use the pec major as a guide in placing a stem in a hemiarthroplasty. Recently, Joaquin showed us in this paper that if you put the stem approximately 4 centimeters above the pec insertion, it's a good approximation of where to put your stem. I generally use that. But also you can just put the stem, it usually rests right on the calcar, and then I provisionally try and reduce the tuberosities to make sure that they over-reduce onto that shaft so that they do heal. Typically, I put my reverses in about 30 degrees of retroversion relative to the forearm, but for RSA for fractures, I will do less retroversion, about 20 degrees, to get more tuberosity surface area and opposition onto that bony ingrowth surface to get it to heal more readily. And then this is from John Levy, a good friend of mine who always comes up with novel concepts. This is the black and tan concept, where he cements and then pressurizes with graft above this. And this works really well. You get ingrowth proximally and temporary fixation with your cement with a polished stem distally. And you can see where the black and tan concept comes from with this beautiful x-ray from John, which shows the cement distally and bone graft proximally. Now, there's lots of ways to repairing your tuberosities. This is how I do it. This is from a great paper from the Exact Tech group. Simovich is the first author. This is color-coded, so I do 2 yellow-orange sutures around the lesser tuberosity, 2 around the greater, around the world cerclage one that you can see in pink here. And I think it's really important to have 2 vertical ones, one around the lesser, one around the greater. And very simple, so I use color-coded sutures, so I can find myself during suture management. I use 2 orthocords, 2 fiber wires, a number 5 fiber wire, and 2 fiber tapes, and it really helps me with suture management. Quick case example, this is a fracture dislocation. I use a cementless fixation. This was 5 years ago plus. I did do an onlay prosthesis, which does require a little bit more pulling. I no longer do that. And then this is the patient 5 years later. You do see some resorption of the tuberosity, which you sometimes see, but you can see on the axillary that it has healed. And patients can do quite well with this. In general, I find fractures for our RSA for fractures do a little less well in terms of motion, but can overall do really, really well. Thank you very much.